about the role of more conservative management, plus or minus steroids, in the treatment of endophthalmitis. And then perhaps we can try and draw some conclusions on a comparison of the two series. Thank you, Jan.
Thank you, Alistair. Good afternoon. I'd like to present some results of doing no vitrectomy at all, and they are data drawn from a recently concluded randomized controlled trial on post-operative post-phaco endophthalmitis. That was a randomized controlled trial in 167 patients, which in fact showed without any doubt that there's no benefit of intravitreal dexamethasone. That's not the topic of presenting it at this moment, but this RCT is a set of carefully selected data, and I'll explain you why it may be of interest for this presentation, for this session. No disclosures. Patients were recruited with a suspected infection after phaco. What we did was take a vitreous biopsy with the cutter, inject a low dose vancomycin, inject a low dose of gentamicin, and 400 microgram of dexamethasone or placebo. That was part of the study protocol. And then 3 or 4 days later, we would re-inject the antibiotics and the dexamethasone and placebo. That is because we had measured before in other studies that if you lower the dose, you must repeat the dose to stay above minimal inhibitory concentration. For gram-negatives, we would switch to ceftazidime if there was the day after proof of gram-negative, because if you re-inject Genta, that might lead to toxicity. We did not in our study exclude patients with bad corneas where you would not be able to see the vitrectomy tip, which is in fact written in the material and methods of the EVS study. Intention to treat analysis at visual acuity at 52 weeks was the outcome measure. There are 70% positive cultures, gram-negatives, and a mixture of gram-positives beside the most prevalent one, the benign coagulase-negative staphylococci. There were some reoperations, and the most severe ones, as in a seeing eye, are 4 retinal detachments. And of course, the most severe operation is that when you really lose the eye and have to eviscerate it. Those were 10 eyes out of 167. Looking at the visual outcome, that is around 0.27 logmar. It's a post-phaco patients. That's different from the patients Victor just described because they were also post-injections and they have macular degeneration, so you cannot compare visual acuities there. But that's a very good visual outcome for most of the patients. Looking here, for instance, I'll come to that later, sorry. And what we found out, and as others did, that the bacteria, that the type of bacteria, the virulence is mostly predictive for outcome. Bad bugs, bad outcome. That, as you see here, all the bad outcome, that is light perception, evisceration, are here in the other gram-positives and the gram-negatives. And the other gram-positives, you can imagine hemolytic streptococci, pneumococci. They are bad bugs. If you compare that to the EVS, larger study, 420 patients, and ours is 167, you see that the percentage of people with over 20/40 vision is almost 70% in our study compared to 53 in the EVS. We did not do vitrectomy, also not in bad corneas, light perception plus presenters, and if we isolate those from our study, 39 patients, and compare that to the best subgroup of the EVS, which is the vitrectomy, core vitrectomy group, that did best in this subgroup. In the EVS, that was a post hoc analysis of LP plus presenters only. Then the difference in number of patients eviscerated is greater in our study, but it's not statistically significant. So strong points of this study: double-blind, placebo-controlled, doctors and patients didn't know in which group they were. The data were prospectively collected, dexamethasone without preservatives, many positive cultures, and we have no change of susceptibility to the antibiotics in period. Final visual acuity, not ETDRS, often because they went back to the referring doctors. Long inclusion period, real-life inclusion rate. Conclusions: no more dexamethasone, even preservative-free. Good outcome for most patients with injections only. The treatment of real bad endophthalmitis remains unresolved. There is a subgroup with bad bacteria, bad bugs, and they have a big risk of ending up being eviscerated. And what can we do in that respect? Role for vitrectomy, not clear at all to me, nor from your presentation, nor from a comparison with the EVS data that were post hoc and also excluding the worst patients. Other adjuvants, that is where your hope should be. There must be something else than just dexamethasone to help you out, to help the antibiotics work. The easiest thing would be to inject your antibiotics much earlier than we do. Thanks for your attention.
Thank you very much indeed, Jan. It's now a great